Good afternoon, everyone, and welcome to our Center of Excellence Grand Rounds webinar number 2, titled Wired for Change, Stroke, Parkinson'S, and Deep Brain Stimulation. I'm Amy Nathan, and I'll be your moderator for today's session. Thank you for taking the time to join us. We're very pleased to have two of our SJMC specialists with us here today, who will be sharing interesting case-based insights and, importantly, practical considerations that can help us in the management and early recognition in these neurological conditions. So we will begin with our first session, titled Case Study on Stroke, presented by Dr. Azizi Bakar, Consultant Neurosurgeon at Subang Jaya Medical Center. Dr. Azizi, thank you for joining us, and I'll hand it over to you. Thank you.
Yeah. Thank you, Amy. Hi, everyone. Thank you for joining this session. My name is Azizi. I'm a neurosurgeon at the SJMC for the last 2 years. We are going to talk about the role of neurosurgery in acute stroke because it's well known. Generally, all stroke patients, when admitted to hospital, usually they will be managed by neurologist, the physician, and usually, commonly, they only refer to neurosurgeon when the patient's life in danger. So the surgery is usually being done to save the patient's life. But things have progressed so much now that we have many roles in all categories of stroke. So basically, what we want now, I want to talk now is basically there are two types. One is the brain ischemic stroke, and another one is hemorrhagic stroke. And then this ischemic, they can occur in many forms, and also the hemorrhagic stroke, it can occur as a large clot, small clot causing a compression of the internal capsule, or in the form of ruptured aneurysm causing hemorrhage, or just a purely spontaneous intravesical hemorrhage. So when we see a patient with the onset of possible stroke, so usually we need to do intervention. Depends on the pathology. If this is ischemic stroke, we try to deliver the definitive treatment within 24 to 48 hours for the best outcome. So beyond 48 hours, the outcome usually not very good. Most likely, patient will be bedridden if they survive. For the large intracerebral hemorrhage, and with herniation syndrome, the time for action usually very short. So we try to deliver definitive treatment within 4 to 6 hours from the onset. So looking at this time frame, so usually if a patient presented with member of GP with a symptom of stroke, usually we don't have much time for patient to be transferred to hospital for CT scan and for further neurosurgical intervention. So, for example, like the pictures from on the left side, lower left side. So for ischemic stroke, so usually we treat patient with anticoagulation, and then we send patient for thrombectomy, endovascular thrombectomy, and we usually when it fails, usually patient will be left to suffer from permanent neuro deficit. So and this is what we're going to try to change the situation, because all this failed intervention, so we can offer something in selected patient so that we can guarantee the outcome is good. So this just to show that the two different scenario, whereas in the left side, the ischemic stroke, usually we have better, longer duration to intervene. So within 24 to 48 hours, okay, for good functional outcome, and up to 72 hours if you're going to make the patient survive. Beyond 72 hours, usually most patient, the chance of survival is very, very low. And in cases with a large intracerebral clot, hemorrhagic stroke. So with a midline shift more than 5 millimeters or more than 1 millimeter, the patient with herniation syndrome, Cushing reflex. So and this we have to to act more urgently. So even though we have a window of 4 to 6 hours of removing the clot, what usually happens is by the time patient arrive to hospital, usually it's already 3 to 4 hours. So and as a international standard, if patient need a CT scan in these kind of cases, so we try to do the CT scan within 15 to 30 minutes of arrival. And if patient need removal of a blood clot or decompressive craniotomy, we try to do it within 60 minutes of arrival. So it's quite challenging, but even in the best neurological center in the world, usually fail to deliver that aims. Yeah. And this is quite common, ischemic stroke involving the middle cerebral artery, the MCA. So, and usually nowadays we see more and more patients actually presenting with total, it's one side MCA stroke without prior history of hypertension or diabetes. They are young patients, they presented with stroke. If it occur on the left side, patient will have a right hemiparesis or hemiplegia and total aphasia. So, and this kind of patient, usually they're quite stable for the first 24 hours, but on second or third day, they start to develop brain swelling, brain edema, causing midline shift, and this midline shift causing supratentorial increased ICP, and this increased ICP will further put a downward pressure on the brainstem. And once the patient start to lose consciousness, so we need to act fast. So usually, what the role for this kind of operation for surgeon is basically we are trying to decompress, allow the brain to swell outwards. So to reduce the pressure on the brainstem. So the recommendation is the minimum opening of the skull is actually 12 by 12 centimeters. So, and then when we open the skull, we open in the other way, means we sloping the bone cutting to allow the brain to bulge outside the skull bone margin without cutting the swollen insulted brain. And sometimes, most of the time, we can do just ipsilateral, one side, the side of the stroke. But in certain situation, we have to open bilaterally. So if we need to open on the other side, so we will do a bifrontal craniectomy. And usually the brain will swell. After the operation, we will put the patient on cerebral protection, usually for 48 hours. And then after 48 hours, we do a CT scan. If the brain condition is still very tight, we will extend the cerebral protection for another 24 hours. And then once the patient condition become more stable, then we will wake them up slowly. Usually the brain will swell around 2 to 3 weeks. Yeah, after the brain start to slack, start to sunken, and then we will put the cranioplasty plate to protect the skull defect. So nowadays, if possible, if fun is not a problem, we try to do a cranioplasty on the same admission because when the brain sunken without the skull there, so actually the the internal vasculature of the brain actually collapse by the weight of the brain itself. So this will hinder the optimal recovery. So when we put the cranioplasty back, so basically we are try to stand the brain so that the blood supply to the brain is not compromised. So the important part of the member of GP is, if possible, if patient present with signs symptoms of ischemic stroke, means they are fairly stable, there's no herniation syndrome, try to refer to neurological center within 48 hours. So, okay, these are the signs of malignant edema. So generally, the patient that being considered for operation is less than 60 years old, but there's no real age cutoff. As long as a patient was well, patient was independent, pre-morbidity, they can drive, they full activity of daily living. So they will be considered, and they must be fit for operation. Usually this operation will take around 45 to 60 minutes. Yeah, and and the operation is based purely is extracranial, so extra cerebral. So we are going to open the skull and open open the dura, doing the duroplasty to cover the back the brain. And these are the warning signs: progressive drowsiness, pupillary asymmetry, and worsening hemiplegia. And the other one is once a patient with ischemic stroke. So, and then they've given the tissue plasminogen activator. They've tried with a thrombectomy. Most of usually up to 80%, 85% of patients will successfully undergo endovascular thrombectomy. So they manage to remove the clot in the big vessel in the brain. But up to 1 in 6 patients actually the endovascular thrombectomy will fail. So either because of the tortuous blood vessel, organized clot, or a very long segment of obstruction. So once failed, so what we can offer as neurosurgeon is basically we do a quick craniotomy, and then we assess the area of the middle cerebral artery. This picture is not very accurate. Usually we open at the bifurcation, the terminal end of the bifurcation. So we open there, and then we remove the clot longitudinally, and the surgery is usually quite quick. Usually will take around half an hour to 45 minutes, and this patient usually we have to operate them while they are on strong anticoagulation, either on Plavix. So, and we vascular neurosurgeon, we are quite used to operate because most of our patients, they are dependent on anticoagulation. We stop the coagulation, they will get stroke. So and and these are the things that new things that available at the moment. And the other thing is hemodynamic stroke. So this is when a patient, usually elderly patient, more than 60, 65 years old. So because of the rigidity of the blood vessel in the brain, so this autoregulation cannot occur normally. So when they lie down or sitting down, they're okay. But when they start to stand up or start to do some activity, they will get aphasia, dysphasia, they get a hemiparesis. So these are the patient where we call it a patient have a hemodynamic TIA or hemodynamic stroke. So in this kind of patient, usually we do some tests to show that at the upright position, patient actually have misery perfusion. This is a critical perfusion that causing a clinical neurodeficit. So in this kind of cases, what usually we can do is we take the blood supply of superficial temporal artery. We harvesting from the inner side of the scalp, and then make a small craniotomy, and then we patch, we anastomose superficial temporal artery to the one of the M2 branch of the middle cerebral artery. The surgery will usually take around 1.5 to 2 hours, and then patient usually on anticoagulation, and we use a lot of machine to assist us for after the bypass. So we measure, we inject the ICG dye to confirm that the bypass is pattern and there's increase in blood flow. And sometimes, if funds allow, we will use Doppler, tiny Doppler sensor to detect the flow of the bypass. So we try to get a flow of more than 20 cc per minute through the bypass. and this kind of patient usually they are well patient, so they are not in active stroke. So usually after the operation, we will wake the patient up immediately and we'll try to mobilize them as soon as possible the next day. And the other role of surgery in stroke is basically if patient have a minor stroke or TIA, and we see patient actually have blockage in the common carotid artery up to the internal carotid artery within 2 centimeters of ramification. So around the cervical 2 level, this is at the angle of the jaw. If the obstruction is below the angle of the jaw, they are amenable for this kind of surgery. So usually this kind of patient, so if the obstruction is not too bad and it's a short segment, usually we will send them for stenting by endovascular radiologist. But if it's long segment, so and this stenting will not be possible, so what usually we do is we open a longitudinal incision down, and then we open the carotid sheath, open the internal carotid artery longitudinally, and then remove the clot, and then we do some intimal tacking to prevent the dissection, and we close. Usually we don't close primarily. We close with the Gore-Tex patch, so that the vessel become bigger, and don't impede the blood supply. So this is quite a straightforward, technically not challenging. So we can complete the operation usually within 45 minutes on one side. The other thing is moya disease and moya-like disease. So the traditional description of moya is this bilateral progressive obstruction of the terminal internal carotid artery in children. But finally, after the COVID pandemic, we see a lot of patients actually of any age, either in the secondary school children, university student, or people still working, or even 65, 70 years old retirees. So all presented with this kind of disease. But because they are not fully comfortable with initial moya description, so we call it like moya disease. But progression-wise, this we call it adult moya disease. They are more aggressive than the children. So and usually the disease is not self-limiting, so they will progress. Initially, when we have this problem, usually we will put patient on anticoagulation, but anticoagulation can only do so far. So when the condition become too critical, so either they're presenting with frequent TIA or documented stroke, or they have seizures, or sometimes they have a bad headache. Then we should consider a bypass. So in this kind of bypass is much more difficult compared to this hemodynamic stroke just now, because in hemodynamic stroke, patient have acute ischemia, so the blood vessel is still very big. So in this moya patient, so the blood vessel has been chronically atrophic. So the blood vessel is very tiny, the wall is very thin, so it's very challenging to do this kind of operation. And that's why sometimes when we do the STA to MCA bypass, stem car bypass, the anastomosis won't survive up to 30%. So that's why we usually don't do bypass in isolation. Usually we combine with take the temporalis muscle, we patch it onto the brain, or we take all the blood vessel on the dura. So and then we patch it into the brains, the arachnoid layer near the blood vessel, so that the ischemic brain will develop new angiogenesis to the blood supply. So post-operatively, usually we don't do an immediate angiogram. We will do a CT angiogram 6 months after the procedure. And even if we don't see an improvement in the post-operative angiogram, usually patient will be much better within 1 to 2 weeks after the bypass. Even we don't do the direct bypass. Sometimes we fail to do a STA MCA bypass. We just patch the muscle, patch the whatever blood vessel onto the brain, so they become better most of the time. And this is a condition where low mobility, where usually operation will take around 2 to 3 hours, and then we wake the patient immediately. And especially in younger children, they because the blood supply increase immediately, so we can see the neurodeficit disappears before our eyes. So they become talkative. They feel their limbs are lighter. They can walk faster. For this intracerebral hemorrhage, so this is bread and butter. Usually, traditionally, is being used to save the patient life. When there's a midline shift, there's an ankle herniation, there's compression to the brainstem. We have Cushing reflex, high blood pressure with bradycardia, pupil dilatation, and traditionally we do in these kind of cases, if patient present to us more than 6 hours after the onset, usually removing the clot itself is not enough. Usually we have to do a decompressive craniotomy at the same time. But if the patient arrives very early, so this is the patient that will not develop brain swelling. So if we remove the clot early, so sometimes we do minimally invasive procedure. So by right, we should do all this image guided surgery, and then we use all this tectography just to avoid the areas of the brain that is essential. But sometimes the investigation in any hospital will take more than 1 hour, so it will delay the operation and increase the risk of morbidity and mortality. And these are the things that getting more frequent at the moment. If a patient having stroke, they have a complete hemiplegia on site, but they're generally well, they're awake, they're alert. And then when we do the scan showed there's a bleeding in the part of basal ganglia we call external capsule. So, and we can see that actually the internal capsule itself is not destroyed, it's not invaded by the hematoma, so it's just being compressed. These are the candidate that if we remove the clot within 12 hours, they will recover fully within 1 to 2 days. Yeah. And we have, and the operation can be done very quickly within half an hour to 45 minutes. And last time we do open surgery, but now most of us do with just with a tube at the size of boba straw, and then we just put inside the brain with a sharp tip, so that we don't cut any brain tissue, image guided into the brain hematoma, and then we evacuate the clot. Yeah, and by the time usually we perform this operation, so usually it's not bleeding anymore. And so the other thing is for aneurysm. So aneurysm usually if aneurysm has not ruptured yet, usually we send for endovascular coiling because it's much faster and easier. But if ruptured, causing a major subrenal hemorrhage with obstructive hydrocephalus, so usually we have to do all the three. We have to decompress the CSF by putting EVD. We have to clear up all the subrenal blood so that it will not block the lymphatic channel. And the other thing is you have to secure the aneurysm either by clipping or trapping. If the aneurysm is so big that we unsafe for us to trap, so what we do is we do a bypass first, and then once the bypass is established, then we trap the aneurysm so that the blood will clot inside it. Yeah, and yeah, this is I mentioned just now when there's a lot of subrenal hemorrhage, so they will block the CSF flow, they will block the lymphatic channel, and nowadays we with the maximum surgical intervention, so we hardly see any morbidity in this kind of patient, mortality in this kind of patients. Yeah, and in patient with hemorrhagic stroke involving the intraventricular hemorrhage, so they will develop hydrocephalus. We need to put EVD. So and then usually put a thrombolytic agent into the ventricle daily. So until we can see clear plane of CSF around the hematoma, then and wait until it disappears. And up to 50% of this patient really they are dependent on CSF diversion. So we need to put a baby shunt method on. So these are the summary of what we can do. So basically this time is brain. So we with this surgical intervention available, so we are hoping that we can get the patient much earlier, so that we can increase the chance of best functional recovery. Thank you.
Hi, Dr. Azizi. Thank you so much for the insightful presentation. Just wanted to ask you a few questions, Doctor, if you're okay.
Yes.
So for patients who undergo neurosurgical intervention following a stroke with you, there are some who might not be able to follow up after that, for multiple reasons. So I just want to ask, what are the key things that you would want a GP to be aware of during their subsequent recovery and follow-ups with them, with the patients
So
itself?
basically, the follow-up depends very much on the functional status of the patient. So for the patient with the modified Redkin scale of 0 to 3, means the patient can walk. So the patient can walk, usually not much we have to follow up, just no typical blood pressure monitoring. But once the patient MRS 4, means they cannot walk, they are wheelchair bound or bed bound, so we have to monitor the complication of immobility, like a pneumonia, pressure sores, depressions. So, and some patients have Rice tube, so they just refuse for us to insert a percutaneous gastrostomy. So this Rice tube have a lot of complication, nasal excoriation, repeated aspiration pneumonia. So these are the things that we need to observe.
Okay, and one more question. If mechanical thrombectomy fails in large vessel occlusion, can selected patients still benefit from neurosurgical intervention?
Yeah, so usually once a patient fail endovascular thrombectomy, so what we need to do is usually by the time the patient already in 12 hours after the initial stroke. So what we do is will the patient benefit from the surgical thrombectomy, open thrombectomy? So we need to do a urgent perfusion scan. If a perfusion scan shows there's a penumbra, large volume of penumbra, more than 6 centimeter in volume, so we will then that is worthwhile to do a mechanical thrombectomy.
Okay. And we obviously have this thing called conservative treatment. When would that come into play, doctor?
So if ischemic, So if patient comes too late after 2 days because of some other reason, so some families they just wait. Okay, patient having developed weakness. Patient, especially when weakness on the left side, mean the stroke is on the right side. So and then the speech area is not affected. Patient still can talk. So they said this is probably
Yeah.
not serious. So they keep going for another few days. So by the time they reach to us, they already passed the danger period, and there's nothing much we can do. So even with maximum intervention, we will not change the outcome. So these are the patient conservative. The other one is when the patient condition is too bad, when intervention most likely will cause will do more harm. We operate and a patient will be hooked to ventilator. These are the patient, so we prefer not to do anything.
Okay. And one last question, Doctor. So, how long would you recommend physical therapy for these patients usually?
Yeah. So initial physical therapy, basically, we are trying to force the patient to become up and about as much as possible because
Yep.
if you leave it to patient and families, they will not do it. Okay, but once everything is set in motion, they know what to do. So usually the physiotherapist is basically it's like a check and balance, like, in the sense that we try to check what they're doing is quite is okay and then enough. So the most important thing is they have to do this on their own by the family members at home as frequent as possible, many times a day. Yeah,
Okay.
and it will be ongoing as much as long as possible.
Okay, understand. Thank you so much, Dr. Azizi, for your
Thank you,
time
Penny. Thank you.
and
Let
for
me answer
answering
to
all
you.
our questions.
Yeah.
Thank you so much. Okay, so next up, we have Dr. Phua, who will be presenting on case study of Parkinson's and deep brain stimulation. Dr. Phua is our consultant neurologist here at Subang Jaya Medical Center. And Parkinson's disease is something that GPs are increasingly likely to encounter, particularly as our population ages. And recognizing when symptoms warrant further neurological assessment can make a significant difference. So we are currently just waiting for Dr. Phua to sign on. Apologies, as Dr. Phua is currently seeing a patient. Just another 3 minutes and he should be on.
There you go. The speaker on already.
Okay, hi Dr. Phua. So
Hi.
today, having your presentation on Parkinson's disease and a little bit on deep brain stimulation. So I'll hand it over to you, Dr. Phua. Thank you.
Yeah, thank you. All good. Hi, good. Okay. All good. Thank you. You want to stay here? Up to you. Yeah. Sorry. Hi. So I'm Dr. Phua. Sorry, I was in the middle of running a clinic. And I'd like to thank you for taking the time to listen to my presentation. The presentation will be for approximately 30 minutes. And I'm going to talk about Parkinson's disease. And due to the limited time, I'm only going to focus on treatment for Parkinson's disease today. So treatment will be part 1, talking about oral therapy. Part 2 will focus on advanced therapies, in particular deep brain stimulation surgery. So briefly about diagnosis of Parkinson's disease. So diagnosis of Parkinson's disease is based on the UK Parkinson's disease brain bank clinical diagnostic criteria. So probably a lot of you will be familiar with the core motor features, which we can all see in our clinical practice. The first and most important core motor feature is bradykinesia. And number 2 will be tremor. But it's important to note that in 1/3 of the patients with Parkinson's disease, they have atremulous Parkinson's disease, meaning they do not actually present with tremor. The third clinical feature, core motor feature, will be rigidity, which you can elicit clinically. And the fourth core motor feature is postural instability, which you can elicit clinically as well. I'll show you some videos later. Some other supportive features, but not core features, would be unilateral onset. So most Parkinson's patients present with unilateral symptoms of tremor, bradykinesia, but not all. So Parkinson's disease is progressive. However, if you find that the patient in front of you is not presenting with progressive symptoms during subsequent follow-ups, you may want to question whether it is Parkinson's disease or not. A lot of patients will have good and sustained response to levodopa. However, the caveat is that some Parkinson's disease patients do not actually show a good response to levodopa. Another supportive feature would be dyskinesias. So if you find that patients, after you prescribe levodopa, present with dyskinesias, it is quite suggestive that you have got the diagnosis correct, which is Parkinson's disease. And if they have on and off fluctuations with levodopa therapy, meaning when you give levodopa, they are good for a couple of hours, and then when the levodopa wears off, they become very stiff and tremulous, then it is suggestive that they have Parkinson's disease as well. So the first core motor feature is tremor, typically rest tremor. We call it pill rolling tremor, usually unilateral, but in this video, this patient presents with bilateral pill rolling tremor in the upper limbs as well as in the right lower limb. Tremor can present in other parts of the body, including over here in this video, the chin as well, and the mouth, perioral tremors. And the second core motor feature, actually the most important core motor feature, is bradykinesia, as I pointed out. And you can elicit this by getting the patient to tap their fingers. We call it finger tapping test. So tap the index and the thumb together. And if you find that the tapping is very irregular and not in a rhythmic fashion, it gets smaller in amplitude and frequency, then these are features of bradykinesia. I mentioned about postural instability. So if you want to examine for postural instability, you go behind the patient, warn them that you're about to give them a firm pull from the shoulder behind to check for their stability, and then you give them a gentle pull, and you see how many steps they take before they're able to stand steadily. If it's more than 5 steps, it shows that they have postural instability. So moving on to treatment, which is the main focus of the talk today. So one point I want to emphasize is there's some misconception in the community about when we should start levodopa therapy. So generally, the earlier you start levodopa therapy, the more good quality of life years you provide for the patient. So this has been shown in this New England Journal paper in 2019. So when you give levodopa therapy early, the UPDRS clinical motor score improves, showing that you're providing more good quality of life years to the patient compared to delayed onset treatment. So treatment, oral therapy for Parkinson's disease, there are a lot of oral therapies available, and they work on various pathways in the basal ganglia. This is just an illustration of the various targets of the oral therapies that you can use. And various formulations are available, various preparations are available, but which one do you choose? So treatment for Parkinson's, the gold standard remains levodopa, and levodopa comes in various formulations. I'm sure most of you will be aware of Madopa, Sinemet, Chun are less available, but Madopa is the most widely used. So Madopa is a combination of levodopa and benserazide. The benserazide component prolongs the effect of levodopa so that more levodopa goes to the brain. Sinemet and Chun work similarly, just a different formulation. And you also have the option of giving Stalevo. So Stalevo is levodopa plus carbidopa and another ingredient called entacapone. Entacapone is a COMT inhibitor, which also prolongs the effect of levodopa in the brain. And finally, you have a long-acting Madopa called Madopa HBS, and this is usually quite useful. I use it mainly for patients who complain of Parkinson's symptoms overnight. So usually they will take this medication at night so that in the middle of the night, they will not feel as stiff as a rock, or if they want to go to the toilet, they will be able to go to the toilet without feeling totally off. Other options apart from levodopa therapy would be the monoamine oxidase inhibitors. such as selagiline, presagiline, and more recently sulfonamide. These therapies are less efficacious, but on the other hand, they have less side effects. So usually these therapies are reserved for patients with mild Parkinson's disease symptoms rather than moderate or severe Parkinson's disease. So these therapies can be used for early young onset Parkinson's patients, but just bear in mind that the efficacy is weaker than levodopa. In terms of other treatment options, another one is dopamine agonist. Options such as pramipexole, ropinirole, rotigotine, and apomorphine are the ones available. And they act similar to dopamine, so they're called dopamine agonists. They stimulate the dopamine receptors directly. However, dopamine agonists carries their own side effects. In particular, dopamine agonists can cause psychosis, severe drowsiness, sudden drop attacks, and sleep attacks. They can present with quite vivid hallucinations. And also bear in mind things like postural hypotension as well. So dopamine agonists, you have to be quite careful when you want to prescribe dopamine agonists. Another side effect I didn't mention is impulse control disorder, which means they become compulsive. They end up gambling all their money away. And for males, sometimes they have hypersexuality. So have to bear in mind side effects of dopamine agonist. So treatment initiation in newly diagnosed Parkinson's disease is either levodopa therapy or dopamine agonist. So they have their own advantages and disadvantages as shown in the table here. Levodopa is the most potent drug. It has immediate symptomatic benefit. It's easily titratable. You can give half a tablet, quarter tablet, or full tablet. As compared to dopamine agonists, they are somewhat less potent, and they are not so easy to titrate, but they carry less risk of dyskinesias in the long run. And in this diagram basically shows the treatment options for newly diagnosed Parkinson's patients. So again, you can start off with levodopa therapy, dopamine agonist therapy, or monoamine oxidase inhibitor therapy. If the patient presents with tremor-only Parkinson's, meaning the tremor is the most bothersome symptom, sometimes you can go get away with just giving trihexyphenidyl monotherapy as well. If those don't work, then what you can do is you can add on subsequent medical therapies such as levodopa plus dopamine agonist, or you can try adding on catecholone methyltransferase inhibitors such as entacapone, or you can add on amantadine as an add-on therapy. And if those don't work, then you can move on to advanced therapies. Advanced therapies are more invasive, and normally we reserve advanced therapies for patients with severe advanced Parkinson's. Having said all this, do not forget about rehabilitation, exercise, physical therapy, occupational therapy, speech therapy are equally important. They have their own role in patients with Parkinson's, because patients with Parkinson's are at very high risk of falls. They are at high risk of dysphagia, at high risk of aspiration pneumonia. They have difficulty managing their activities of daily living. They may have psychosocial psychiatric manifestations. So all these need to be looked into as well. So do not only focus on the motor symptoms, but you need to keep a close eye on the non-motor features as well in Parkinson's disease. So I talked about pharmacotherapy for Parkinson's, such as levodopa, dopamine agonist, but they also carry significant side effects if doses go too high. For example, they can have dyskinesias over the long run. They can have worsening of autonomic dysfunction, such as postural hypotension, drowsiness, sleep attacks, as I mentioned, cognitive neuropsychiatric side effects such as depression, hallucinations, psychosis, delusions, anticholinergic side effects, cognitive side effects. So when you prescribe pharmacotherapy, you need to bear in mind all these side effects as well. So briefly about non-pharmacological therapy. So for every single patient with Parkinson's disease, you also need to focus on rehabilitation. So exercise therapy for Parkinson's, you need to focus on a few modalities. So you need to focus on aerobic activity. Aerobic, you can simply ask them to go for 20-30 minutes of walk per day. You don't have to ask them to run. Most of them will not be able to run anyway. So simple daily walks, 20-30 minutes a day, that's good enough. Strength training is important. Patients with Parkinson's, because they don't move as much, they are at very high risk of osteoporosis. So you can ask them to buy some light dumbbells, do some gentle strength training if they're able to, buy a rubber band resistance. And if they are able to or can afford it, get a home-based physiotherapy or attend some Tai Chi or some Qigong classes, just a gentle strength training exercise. Balance, agility, again, the Qigong and Tai Chi therapies are very good for that. Stretching, you can ask them to join some gentle yoga therapy as well. Home-based stretching exercises are very useful as well. So this is a graph to illustrate the importance of exercise. So in a patient who does not exercise, you can see that the amount of dopamine in the brain goes down significantly over time, which is the line graph in red. But if you get them to exercise, the amount of striatal dopamine neurons, they decline slower. So they have more dopamine reserve in the brain compared to someone who does not exercise. So I just wanted to highlight the importance of Tai Chi or stretching exercises in Parkinson's patients. You can see that with some gentle exercise, regular exercise, the percentage of Parkinson's patients who fail over time is comparatively less compared to someone who does not. Exercise also improves non-motor symptoms in Parkinson's. Exercise improves their sleep, reduces their depression. When they engage socially, they are more active. They are generally happier. It slows down their cognitive decline and it boosts their energy level as well. Over time, Parkinson's disease, as we know, is not curable. It will get worse and worse with time. It's inevitable. We do not have a cure for Parkinson's. And as time goes by, the therapeutic window for treatment with oral therapy becomes narrower and narrower. And the side effects from oral therapy becomes more and more pronounced and more frequent. They get dyskinesias. They have more and more and longer off periods. And this is unfortunately the natural progression of Parkinson's disease. So when this happens, we would sometimes move on to advanced therapies. Before that, we classify motor fluctuations in Parkinson's disease to a few patterns. The first one is wearing off, meaning when you give the levodopa tablet, it may work for 2-3 hours and then the effect wears off. So that's called wearing off. The second motor fluctuation in Parkinson's is called delayed on, meaning initially when you gave levodopa, it may work within 15 minutes. But as the years go by, it takes longer and longer to work, and it may only start kicking in 2 hours or 3 hours later. The third pattern is called dose failure. So when you give levodopa, the medication does not kick in at all. So this can happen in patients with severe constipation, which is very common in Parkinson's because they have delayed gastric emptying. And the final pattern is random on and off. So you give levodopa expecting it to work within half an hour, but then it doesn't kick in. And then it may kick in 2 hours later, and then the next dose, it doesn't kick in. So you get this yo-yo effect with the oral therapy. So moving on to advanced therapies, we usually reserve advanced therapies for patients with motor fluctuation that is becoming harder and harder to manage with oral therapy alone. So in Malaysia, the most common advanced therapy that we have at the moment is deep brain stimulation surgery. Other advanced therapies such as the apomorphine pump and the duodopa gel infusion is unfortunately not available yet. So I'm going to focus on deep brain stimulation surgery. So we know from studies that deep brain stimulation in Parkinson's disease is a tried and proven therapy. This therapy has been used worldwide for many, many years, initially in the Western countries, and now more and more so in Asian countries as well. And deep brain stimulation, as shown in this illustration, reduces dyskinesias, reduces the amount of medication the patient needs to take, improves their quality of life significantly, improves their mental health significantly, and improves their social function as well. So I'm going to show a video of deep brain stimulation surgery done earlier this year. This video courtesy of SJMC. So please enjoy. Okay, I hope you guys have enjoyed the video. I'll move on. So deep brain stimulation surgery, we certainly do not do it in all patients with Parkinson's. Generally, we quote about maybe 5 to 15% of patients only are considered suitable candidates for DBS. However, it remains underutilized. So we want to create awareness about this option for patients with severe Parkinson's. And it's underutilized maybe because some patients are not referred, or sometimes they're referred too late until they are not suitable for surgery. Sometimes they have misconceptions or fear about the surgery. And hopefully we can try to create awareness and address some of these issues around DBS. So which patients are suitable for deep brain stimulation surgery? Generally, we do not do DBS in patients with Parkinson's more than 80 years of age for reasons, common sense reasons. If they're more than 80, chances are their cognition might not be so good. To undergo DBS, you really need to be quite with it. You must be, because the DBS, you need to be able to do some self-programming at home. So generally, we try to avoid doing DBS in patients more than 80 years of age. So DBS generally suitable for patients with severe Parkinson's, when they have severe motor fluctuations, marked dyskinesias. Generally, if they have a robust levodopa response, meaning when you give the levodopa tablet, they have a good response to the tablet, meaning they generally will have a good response to this surgery. Absence of dementia, of course, if they have significant dementia, then they will not be suitable for this surgery. If they have severe depression or anxiety, this surgery is not suitable for them, as it may worsen their psychiatric symptoms. DBS patients are suitable for DBS only if they have good social support or caregiver support, because DBS, once it's put in, you need to be able to know a little bit about programming and charging as well. So there must be good family and social support for patients for DBS. Some symptoms of Parkinson's will improve with DBS, some do not. The cardinal motor features generally will. Tremor will improve generally quite significantly. Rigidity will improve. Bradykinesia will improve. The dyskinesia will. The motor fluctuations, yes. But certain symptoms such as speech, swallowing difficulty writing, freezing, balance issues generally do not improve or improve minimally. So we really have to assess the patient and ask what are your most troublesome symptoms, and then we will evaluate whether they are suitable for this surgery or not. So that is a quick overview about Parkinson's, and DBS is something that we have started in SJMC earlier this year with the help of Professor Kalai, who has joined us from University of Malaya. So we are quite excited about this new option for patients with advanced Parkinson's, and we are doing approximately 1 to 2 cases a year, and we hope to do more in the years to come. Thank you very much for your attention. Any questions? I think there's one question from the audience on the chat.
Dr. Phua, so we have one question. What are contraindications for DBS? Just one short one. Yeah. Dr. Phua, hi.
Hello.
Yeah, we have one question. So the question is, what are the contraindications for DBS?
Contraindication or DBS, I think I briefly touched on it just now. So in patients with, I will just go back to my slide. So if they have dementia, no, they're not suitable for dementia. Age is another limiting factor. Very elderly patients, high risk of surgery, we will not subject them to surgery. So they must have a unequivocal diagnosis of Parkinson's. DBS is only suitable for idiopathic Parkinson's. If you have patients with Parkinson's plus conditions such as multiple system atrophy or progressive supranuclear palsy, those conditions will not respond to DBS. And patients with severe depression, anxiety, delusions, hallucinations, schizophrenia, not suitable for DBS because DBS surgery can worsen these symptoms. Patients with suicidal ideation, not suitable as well. These are some of the contraindications, no for surgery.
Okay. Thank you so much, Dr. Phua. So we will maybe get you to address the other questions post-webinar so we can post it in the comments. I understand you have to go for a clinic. Thank you so much for joining us today.
Thank you for taking the time.
Thank you. Okay. Thank you once again to both